My name is Dr. Srivastav. I work for Fortis ESCORTS Heart Institute. I am currently the Director of Non-Invasive Cardiology and I head the research department here too. Dissection of aorta is a very confusing disorder because unless you have a keen suspicion, you will never be able to diagnose dissection of aorta. History is extremely important. If there is somebody who's got a boring pain which goes from front to backwards or it is radiating towards both the legs, the sharpness of the pain, if it is radiating towards the legs, it invariably and always means that you are dealing with something nasty in the aorta. Unfortunately, the ECGs most of the times are normal unless it is dissecting into the coronary arteries. But the clinical cues are most often than not, the patient would be having hypertension. If you look at the pulses, there can be unequal pulses. If there is a person who has got absent pulses in one limb or other limb or into the carotids, then rest assured that it is aortic dissection. Now, ECG can be very fallaciously normal. The enzymes can be fallaciously normal. And that is the reason why a high index of suspicion is needed to make a diagnosis of dissection of aorta. Now, once you have had this suspicion that there is dissection of aorta, then the first test which you should do immediately is echo. Many a times you can potentially miss it too, because the limitation of transthoracic aorta is transthoracic echocardiography is that it sees or looks at only very limited quantum of ascending aorta. If you want to trace the aorta, then the next best option which can be done bedside even in a very sick patient is a transesophageal echo. Once you do a transesophageal echo, you can see a classical flap. This flap may or may not be able to be differentiated several times with artifacts, but there are ways and means to sort that out too. You can see the leakage of the valve, and here is an example which can be seen which shows that there is a dissection of aorta along with leakage of the aortic valve, and this is how you make a diagnosis. It is so important that we इसको edit कर लेना, but
no problem.
इसके अंदर यहाँ पे this is the place where you will have to show the picture. Now, there are several times you would be still confused because artifacts versus true dissection can be very confusing at times, and this is the time when you should not be shamed from using multi-speciality or multi-imaging modalities. CT scan has come of age and it has become probably the gold standard to find out dissection of aorta. The reason why you should be so careful and so meticulous in finding out dissection of aorta is because if it is the ascending aorta dissection, then the prognosis is very bad. In fact, the modality is so bad that you will start losing 1% patient per hour. So in next 48 hours, half your patients would be dead. And at the end of 1 year, probably 90% or greater would be dead. So it is so important that you have to, there is no scope that you can miss an ascending aorta dissection, because then you are announcing doom for the patient, almost a disaster. So first and foremost is transthoracic aorta in echocardiography. In case you are not able to pick it up in that, go ahead with transesophageal echo. If not, then go for a CT scan. Several times you will find that the CT scan is a challenge because people would be, if in case the dissection has gone into the kidney arteries, their kidney parameters can be low. That is the time when you can take help of MRI. But the problem with MRI is that one study of MRI takes so much more longer. It is necessary that you make the diagnosis of aortic dissection very early.